Okay, let's unpack this. We know that studying hematology for the AKT exam can feel, well, a bit overwhelming, can it? Like walking into a room full of acronyms and confusing timelines.
It absolutely can. It
Yeah.
feels vast. But, the truth is the RCGP isn't necessarily testing your deepest pathology knowledge here.
Right.
It's more about your triage skills. Can you spot that red flag? Do you know the right referral timeline? That's the crucial bit for a GP.
Exactly. And that's really our mission today. We've got this comprehensive reference guide specifically geared towards you, the GP trainee, and we're essentially stripping out everything but the highest yield clinical gold. We want to focus specifically on those differentiation points, the things that look similar but aren't,
Yeah, the easy confusion points.
the non-negotiable red flags,
Yeah.
and crucially, the urgent management pathways you need to know cold for primary care.
And we're structuring this deep dive around that idea of time and urgency. So we'll hit the malignancies first, really stressing those critical 48-hour and 2-week wait triggers. Then we'll pivot to the bread and butter stuff, the common anemias,
Right.
and finish up with some key systemic disorders that often just sort of present vaguely in the surgery. Knowing when to act fast, that's non-negotiable for this exam.
Right. Let's start with the thing I think every GP trainee probably dreads a bit. Suspecting cancer. We'll begin with leukemia. Defined simply, it's a malignancy of the white blood cells.
Yep.
And it gets categorized by the specific cell line involved and whether it's acute, so rapid onset, or chronic, more insidious.
Exactly. And as that first point of contact, the challenge is how do you actually catch it when the symptoms are often so vague, so nonspecific?
Yeah, they can mimic so many things.
They really can. You
Yeah.
catch it by recognizing the pattern. It's about seeing a constellation of nonspecific symptoms that signal something's wrong with the bone marrow, either failure or infiltration.
Okay.
And NICE guidance is very explicit here. They give you 7 crucial clinical pointers that should immediately make you think, right, 48-hour FBC for suspected leukemia.
And this urgency is key, isn't it? Because these symptoms could easily be brushed off as a viral illness.
Easily. That's why knowing these triggers is so high stakes. Missing them delays diagnosis.
Okay, let's nail those 7 pointers then, because
Yeah.
getting these right is vital. The core themes seem to be signs of anemia, so pallor,
Wow.
and that persistent, unexplained fatigue.
Right, the tiredness that doesn't get better with rest.
Exactly. Then signs of abnormal white cells, unexplained fever, getting infections over and over again.
Recurrent infections, yeah.
And then the physical signs,
Yeah.
unexplained bruising, or those little pinpoint petechiae suggesting low platelets,
Thrombocytopenia, yep.
generalized lymphadenopathy, so swollen glands everywhere, not just one area.
Yeah.
And finally, unexplained hepatosplenomegaly, so an enlarged liver or spleen.
That combination, anemia, infection risk, and bleeding tendency, that's the classic triad pointing towards bone marrow failure.
Okay.
If that 48-hour FBC comes back abnormal, then you're rapidly moving into the next step, differentiating acute from chronic. Acute forms are genuine emergencies.
Life-threatening, right?
Absolutely. Chronic forms, well, the initial management can be quite different, often much more nuanced.
So the acute leukemias, we've got AL, acute lymphoblastic, and AML, acute myeloid. They're characterized by that rapid, really aggressive proliferation of immature cells, right? So symptoms pop up over days or weeks.
That's right, it's fast. If we contrast them, AL is mainly a disease you see in children. The peak age is around 2 to 5 years old.
Okay.
And the presentation is usually very acute. The child is suddenly really unwell, overwhelming tiredness, maybe breathless, and often these sort of non-specific joint pains.
Joint pains, why is that?
It's often from the leukemia cells infiltrating the bone marrow, causing pressure and pain. It can sometimes mimic things like juvenile arthritis initially.
Okay. And the management pathway is pretty intense.
Very intense. Chemotherapy, steroids, it often stretches out for about 3 years. But the good news is the prognosis in childhood ALL is actually excellent now.
That's good to hear. Okay, so then AML, acute myeloid leukemia, that's more common in adults.
Yes, much more common in adults, and the incidence really climbs sharply after the age of 60.
And the presentation, still acute.
Still acute, but often dominated by the symptoms of that bone marrow suppression we talked about. So patients are pale, incredibly tired, they might have high fevers, persistent infections that just won't clear, and often significant bleeding problems like nosebleeds that won't stop or bleeding gums.
Right.
And here's a key lab detail to remember for AML, especially compared to ALL. While ALL might show high, low, or normal white counts initially, AML often presents with significant pancytopenia on that first FBC.
So everything's low. Red cells, white cells, platelets.
Often, yes. It reflects that the malignant myeloid blasts have almost completely taken over the marrow, suppressing all the normal cell production.
Wow. And management is aggressive chemo.
Highly aggressive chemotherapy aimed at inducing remission. It has to be, given how quickly it progresses.
Okay, now let's pivot to the chronic leukemias. You said the timeline is completely different here.
Totally different. We're not talking days or weeks. We're talking an insidious onset, creeping up over many months, sometimes even years. And thankfully, these are rare in children.
Right, so which one are we most likely to encounter?
The commonest leukemia you'll probably see, or at least diagnose incidentally, is chronic lymphocytic leukemia, CLL.
CLL, yeah.
This overwhelmingly affects older people, typically over 60. And the presentation, honestly, is often incredibly vague. Just generalized tiredness, maybe noticing they're catching more colds, a bit of unusual bruising, sometimes nothing at all.
So it might just be picked up on a routine blood test.
Very often, yes. An incidental finding of a high lymphocyte count on an FBC done for something else entirely.
And the key AKT point for CLL management, you mentioned nuance.
Yes. It's remembering the initial approach is often watch and wait.
Watch and wait, so no immediate treatment.
Often not. Because the disease usually progresses so slowly, especially in older, potentially frailer patients, starting aggressive treatment straight away might cause more harm than good. Treatment is usually held back until the disease is clearly causing problems, worsening symptoms, rapidly rising counts, troublesome lymph nodes.
Okay, that makes sense. And when treatment is needed.
Well, the field is changing rapidly. Increasingly, it's moving towards targeted drugs like ibrutinib. These are much smarter drugs than traditional chemo for this type of leukemia.
Interesting. Okay, so that's CLL. What about the other main chronic one?
That would be chronic myeloid leukemia, CML. This tends to affect more middle-aged adults. Again, the features can be pretty nonspecific, maybe some weight loss, feeling full quickly because of an enlarged spleen, just general malaise.
Feels like a theme here with vague symptoms.
It is. That's why the blood tests are so vital. But CML has something very specific, a diagnostic hallmark.
Which is?
It's defined by one single non-negotiable genetic marker, the BCR-ABL fusion gene.
BCR-ABL.
You'll find it on a shortened chromosome 22, which has a famous name, the Philadelphia chromosome.
Ah, the Philadelphia chromosome. Heard of that.
If you see CML mentioned in an exam question, your brain should immediately flash BCR, ABL, and Philadelphia chromosome. They are intrinsically linked.
And does that specific gene affect treatment?
Massively. The discovery of this gene and the protein it produces led directly to the development of targeted therapy. The drug imatinib specifically blocks the action of that BCR-ABL protein.
Right.
And it completely transformed CML. It went from being basically a fatal disease to a manageable chronic condition for most people, a real success story of targeted therapy.
Wow, okay, so that's leukemia covered, acute versus chronic, the key triggers. Now, moving from circulating blood cells into the lymphatic system, let's talk lymphoma.
Right, lymphoma, a neoplastic disorder starting in the lymphoid tissues, lymph nodes, spleen, etc. And the distinction from leukemia is important because the referral pathways and initial workup can differ.
Okay, how do we differentiate the main types? Hodgkin's versus non-Hodgkin's?
The absolute core difference comes down to the pathology, what you see under the microscope. If the pathologist reports finding large multinucleated cells called Reed-Sternberg cells,
Reed-Sternberg cell.
you are dealing with Hodgkin's lymphoma.
Okay, and Hodgkin's tends to affect younger people.
It has a bimodal age distribution, peaks in the 20s and then again in the 70s, but yes, often associated with younger adults compared to non-Hodgkin's. It also tends to spread in a more predictable, sort of stepwise fashion through adjacent lymph node groups.
And the classic presentation for Hodgkin's.
Typically, it's a painless, persistent lymph node, often in the neck or above the collarbone. It just sits there, maybe grows slowly. And it might be associated with those systemic symptoms we call the B symptoms.
Ah, yes, the B symptoms, remind us.
Unexplained weight loss, and it has to be significant, usually more than 10% of body weight in 6 months, drenching night sweats needing to change pajamas or bedding, and recurrent unexplained fevers.
Got it. Weight loss, night sweats, fever. And these are prognostically important too, right?
Yes, the presence of B symptoms often indicates more advanced disease and can influence treatment decisions.
Okay, now contrast that with non-Hodgkin's lymphoma.
Right. Non-Hodgkin's lymphoma, or NHL, actually accounts for the majority of lymphoma cases. It typically affects an older age group than Hodgkin's. And the crucial cellular difference, No Reed-Sternberg cells.
No Reed-Sternberg cells in NHL. Okay.
The presentation is often more widespread from the start, maybe generalized painless lymphadenopathy, so swollen nodes in multiple areas.
Hmm.
B symptoms can occur, but maybe less commonly than in Hodgkin's. And NHL is more likely to involve sites outside the lymph nodes, what we call extranodal
What
sites.
with where?
Oh, the gut, skin, bone marrow, brain. It's less predictable in its spread.
So as the GP, seeing these potential signs, the persistent node, the splenomegaly, maybe B symptoms, how do we translate that into urgent action? What are the 2-week wait triggers here?
Okay, this is key for the AKT. For any adult patient presenting with unexplained lymphadenopathy, meaning swollen glands that you can't explain by infection, that have been there for, say, longer than 6 weeks or getting bigger,
Right.
that warrants a 2-week wait referral for suspected Hodgkin's lymphoma.
Okay. Unexplained, persistent, or progressive lymphadenopathy minus 2WW.
Exactly. For non-Hodgkin's, the trigger is slightly broader. It's unexplained splenomegaly or generalized lymphadenopathy.
So enlarged spleen on its own could be a 2WW for NHL.
Yes, if it's unexplained. The key is always persistence and the lack of an obvious infectious cause.
And management for both involves the usual suspects: chemo, radiotherapy, steroids.
Broadly, yes, those are the mainstays. But it's worth noting, especially for non-Hodgkin's, the increasing use of targeted immunotherapy, particularly a drug called rituximab.
Rituximab.
Yeah, it's a monoclonal antibody. It targets a specific protein called CD20, which is found on the surface of most B cells. Since many NHLs are B-cell lymphomas, rituximab has become a cornerstone of treatment and has really improved outcomes.
Ah, another example of targeted therapy based on the cell type.
Exactly. Understanding whether it's a B-cell or T-cell lymphoma really guides the modern treatment strategy.
Okay, brilliant. Our final malignancy in this urgent section is multiple myeloma, a disease of plasma cells, right? The ones that make antibodies.
Precisely. Malignant plasma cells, these are the most mature form of B lymphocytes, the antibody factories.
And what goes wrong in myeloma?
Well, these malignant plasma cells start proliferating uncontrollably within the bone marrow. They crowd out normal blood production. They secrete chemicals that damage the surrounding bone.
Ah, hence the bone pain.
Exactly. And crucially, they produce vast quantities of abnormal identical antibodies, what we call a paraprotein or M protein. You can detect this in the blood serum.
Paraprotein in the serum, okay?
And they often also produce fragments of antibodies, the light chains, which spill into the urine. These are called Bence-Jones proteins.
Bence-Jones protein in the urine, got it. And isn't there a premalignant stage?
Yes. Very important to know about MDUS, monoclonal gammopathy of unknown significance.
MGUS.
This is where you find a small paraprotein, incidentally, perhaps on tests for something else. But the patient has no symptoms or signs of myeloma, no bone disease, no kidney problems, no anemia.
And it's unknown significance because...
Because while most people with MGUS never develop myeloma, there's a small but definite risk, about 1% per year, of it transforming into full-blown myeloma or a related disorder. So patients with MGUS need lifelong monitoring.
Okay, so MDUS is the precursor. But for actual myeloma, how do we spot it?
You mentioned bone damage and paraproteins.
Yeah, the key is understanding the systemic damage caused by both the plasma cell infiltration and that paraprotein. The classic mnemonic used to be CRAB.
Calcium, renal, anemia, bone.
Exactly. But our source material helpfully details 5 key effects you really must have locked down for the AKT.
Okay, let's hear them.
First, severe bone pain, often in the back, ribs, or long bones. And because the bone is weakened, patients can get pathological fractures from minimal trauma. This is often linked to high calcium levels, hypercalcemia, released from the damaged bone. Okay, bone pain and fractures, often with high calcium. What else?
Second, anemia, due to the marrow being crowded out. Third, recurrent infections, because the normal antibody production is suppressed, leaving patients vulnerable.
Makes sense.
Fourth, renal failure. This is often due to those Bence-Jones light chains physically blocking up the kidney tubules, but hypercalcemia and dehydration also contribute.
Kidney problems are common then.
Very common. And fifth, often significant, unexplained weight loss.
So bone pain, anemia, infections, renal failure, weight loss. It sounds like it could present in many ways. Back pain, fatigue, recurrent UTIs.
Exactly. That's why the GP's role in picking it up is so vital, especially as it predominantly affects older people. Our sources are really specific about the investigation triggers, particularly for patients over 60.
Okay, what are those triggers?
If a patient over 60 comes to you with persistent, unexplained bone pain, especially back pain, or they've had a fracture after very little force,
All right.
the first step is simple screening blood tests. Get an FBC, check the plasma viscosity, or ESR. These are looking for non-specific signs of inflammation or anemia.
Okay, FBC, ESR viscosity as a first screen for over 60s with bone pain.
Yes. But here's the absolute crunch point, the critical time-sensitive step you need to know for the AKT.
Okay.
If any of those initial screening tests, the FBC, viscosity, or ESR comes back abnormal, or if the patient has unexplained hypercalcemia or a low white count, leukopenia,
Yes.
that patient immediately goes on to the very urgent 48-hour testing pathway. Not 2-week wait, 48 hours.
48 hours. Wow. What tests need doing in that time frame?
Within those 48 hours, you need to arrange serum protein electrophoresis to look for that paraprotein band, a serum-free light chain assay, which is more sensitive than electrophoresis sometimes, and a urine Bence-Jones protein test.
Serum electrophoresis, serum-free light chains, urine Bence-Jones, all within 48 hours if the initial screen is positive or there's high calcium, low white count.
That's the non-negotiable step before you make that urgent referral to hematology. Getting those tests done fast is key.
And the prognosis for myeloma.
Unfortunately, it's still considered incurable, and the prognosis remains relatively poor, although treatments are improving. Management focuses on controlling the disease, relieving symptoms, using drugs like cyclophosphamide, steroids, bisphosphonates to protect the bones, and sometimes stem cell transplants in younger, fitter patients.
A sobering note to end the malignancy section on. Okay, let's change gear. So we've covered the really urgent, life-threatening malignancies. Now let's pivot to probably the most common diagnostic challenge related to blood we see in primary care: anemia.
Absolutely. Bread and butter stuff, but easy to get wrong.
Defining it is simple enough: low hemoglobin below the threshold. But the symptoms, oh, they're so maddeningly generic, aren't they? Fatigue, shortness of breath, dizziness, looking pale.
Exactly. You absolutely cannot diagnose the cause of anemia based on symptoms alone. You need the lab data to guide you. And the first, most essential piece of that data is the mean cell volume, the MCV.
The MCV, the size of the red blood cells.
Precisely. It acts like your initial triage tool. It instantly helps you organize your differential diagnosis into logical categories.
Okay, let's nail this classification for the exam then. If the MCV is low, meaning the red cells are small, we call that microcytic anemia.
Correct. And the three main causes you need to think of are
Iron deficiency anemia, thalassemia, and much less commonly lead poisoning.
perfect. IDA, thalassemia, lead. Those are your top three microcytic causes.
Okay, what if the MCV is high? Large red cells.
That's macrocytic anemia, and the two big ones here, the ones you absolutely cannot miss, are B12 deficiency or folate deficiency.
U12 and folate, got it. Any others for macrocytic?
Yes, definitely keep alcohol excess in mind. Also, liver disease and an underactive thyroid hypothyroidism.
Alcohol, liver, hypothyroid. Okay, so
Yep.
microcytic, macrocytic. What about the middle ground? Normal MCV.
That's normocytic anemia, and this bucket includes quite a few things. Anemia of chronic disease is a big one. Think kidney failure, chronic inflammatory conditions like rheumatoid arthritis. Also, acute blood loss will initially be normocytic before iron deficiency develops. The physiological changes in pregnancy can cause a mild normocytic picture too.
Okay.
And here's a really important one, a potential AKT trap, a mixed deficiency.
Mixed deficiency.
Yeah, imagine someone has both iron deficiency, which makes cells small, and B12 deficiency, which makes cells big.
So they sort of cancel each other out on the MCV.
Exactly. The microcytic tendency fights the macrocytic tendency, and you can end up with a falsely reassuring normal MCV, even though the patient has two significant deficiencies.
Wow, okay, so a normal MCV does not rule out deficiency. That's a key point.
Absolutely critical point. Always look at the whole picture, not just the MCV in isolation.
Okay, let's dive deeper then, starting with the microcytic anemias. Top of the list, iron deficiency anemia, IDA, the most common cause worldwide, right?
By far. And the causes are always about an imbalance. Either not enough iron coming in or too much going out. Usually it's chronic blood loss.
Like from the gut.
Yes. Think GI malignancy, peptic ulcers, significant gastritis, even things like hookworm in some parts of the world, or very commonly in women of reproductive age, heavy periods menorrhagia.
Right. Or problems absorbing iron.
Yeah, malabsorption syndromes like celiac disease or after certain types of gastric surgery, less commonly now, poor dietary intake alone, but it contributes.
Clinically, we might see those classic textbook signs, though maybe not that often in reality. Things like koilonychia, the spoon-shaped nails.
You might, or angular stomatitis cracks at the corners of the mouth. But honestly, the diagnosis hinges on the blood results.
Okay, so what's the classic blood picture for IDEA?
You'll see low hemoglobin, obviously, low MCV, confirming it's microcytic, often a low MCH mean cell hemoglobin, meaning less hemoglobin per cell.
Okay, low HB, low MCV, low MCH.
But the absolute gold standard test, the one that confirms depleted iron stores, is a low ferritin.
Low ferritin, that's the key.
That is the key differentiator for IDEA. And because the body is desperate for iron, it ramps up its capacity to bind and transport iron. So you typically see a high TIBC, total iron binding capacity.
Low ferritin, high TIBC. That screams IDA.
It does, and management is critical for the exam. Two parts. First, you must investigate and treat the underlying cause. Especially in older patients, you have to rule out GI malignancy. Don't just treat the anemia without finding out why they're anemic.
Crucial point, don't just prescribe iron, find the cause.
Exactly. Then, alongside dietary advice, you initiate oral iron replacement.
And the specifics matter here for the AKT, don't they? Dose and duration.
They do. Typically, it's around 65 milligrams of elemental iron per day. That's usually one standard tablet of ferrous sulfate 200 milligrams taken once daily. And the duration is important. You treat for a minimum of 3 months after the hemoglobin level has returned to normal.
3 months after normalization. Why so long?
To replenish the body's iron stores, reflected by the ferritin level, just correcting the HB isn't enough. You need to refill the tank.
Okay. And IV iron. When do we use that?
Reserved for specific situations. If someone genuinely cannot tolerate oral iron despite trying different preparations or doses, if they have severe malabsorption where oral iron won't work, or if you need to raise their HB level very quickly, perhaps before major surgery.
Got it. Okay, now let's compare that IDA profile, low MCV, low ferritin, with the other common microcytic condition, thalassemia trait.
Right. Thalassemia is an inherited disorder, autosomal recessive, affecting the production of globin chains, which are part of hemoglobin. It's common in people with ancestry from the Mediterranean, Middle East, South Asia.
And trait means they're a carrier, heterozygous.
Exactly. They've inherited one faulty gene. Thalassemia trait causes a mild, often completely asymptomatic microcytic anemia. The person usually feels fine.
So how do we tell it apart from IDEA, especially if they both cause low MCV?
This is the absolute vital differentiator you must know for your exam. You look at the iron studies, specifically the ferritin.
Okay.
In thalassemia trait, the FBC shows low MCV, low MCH, but the ferritin level is normal or even high.
Normal or high ferritin. That's completely different from IDEA.
Completely different. It's not a problem of iron quantity, stores are fine. It's a problem of iron utilization. The factory can't use the iron properly to make enough normal hemoglobin because the globin chain production is faulty.
So if you see someone with persistent microcytic anemia, maybe they've already tried iron tablets with no improvement, and you check their ferritin and it's normal.
You must immediately think, could this be thalassemia trait? Stop the unnecessary iron and arrange hemoglobin electrophoresis for confirmation. Giving extra iron to someone with thalassemia trait is not helpful and could potentially lead to iron overload down the line.
That's a massive clinical pearl right there. Differentiate IDA from thal trait using ferritin.
Huge. And just briefly, the severe form, beta thalassemia major, where someone inherits 2 faulty genes, is a very different beast. These patients are transfusion dependent from early childhood.
Requiring regular transfusions.
Yes, usually every few weeks for life, which then leads to the problem of iron overload from all the transfused red cells. So they also need a lifelong iron chelation therapy to remove the excess iron, a complex condition managed by specialists.
Okay, understood. Let's shift gears now to the macrocytic anemias, the big cells. You said B12 and folate deficiency are the key players here.
They are. And let's start with B12 deficiency because this one carries that extra layer of risk due to the potential for neurological damage.
Right. The neurological side is unique to B12.
Predominantly, yes. Folate deficiency doesn't typically cause the same neurological problems. Now, B12 deficiency takes quite a while to develop. Why? Because our liver stores a lot of B12, maybe 2 to 5 years worth.
So it's usually not acute dietary lack.
Rarely just diet, unless someone is a very strict long-term vegan with no supplementation. More often, it's an absorption problem. B12 absorption is complex. It needs something called intrinsic factor, or IF, which is made by parietal cells in the stomach lining.
Intrinsic factor.
Okay.
Okay, so what stops absorption?
The classic cause is pernicious anemia. This is an autoimmune condition where the body attacks either the parietal cells themselves or the intrinsic factor directly. No IF means no B12 absorption in the terminal ileum.
Pernicious anemia, the autoimmune cause. Any other causes?
Yes, anything that damages the stomach or removes it, like a gastrectomy. Conditions affecting the terminal ileum where B12 is absorbed, like Crohn's disease. And certain drugs can interfere with absorption too. Metformin is a common one. Also colchicine, some anticonvulsants.
Metformin. That's important to remember given how common it is.
Very important. Now, beyond the general anemia symptoms, fatigue, breathlessness, and maybe a sore tongue, glossitis, what makes B12 deficiency so critical is its impact on the nervous system.
Why does it affect nerves?
B12 is essential for maintaining the integrity of the myelin sheath that insulates nerve fibers. Without enough B12, demyelation can occur.
And that causes...
The range of neurological symptoms. You absolutely must ask about these. Signs of peripheral neuropathy, tingling, pins and needles, numbness, often in the hands and feet. Vision changes, cognitive decline that can mimic dementia, muscle weakness, and the most feared complication, SACD.
SACD.
Subacute combined degeneration of the spinal cord.
Sounds serious.
It is. It's demyelination affecting specific tracts in the spinal cord, the posterior and lateral columns. This leads to progressive problems with balance, gait, ataxia, and stiffness, spasticity. If it's not caught and treated early, the damage can be permanent.
Wow. So recognizing those neurosymptoms is vital. How do we investigate for pernicious anemia specifically?
We look for the autoantibodies. You can test for anti-intrinsic factor antibodies. These are very specific if positive, and also anti-parietal cell antibodies, which are sensitive but less specific.
Okay. Anti-IF and anti-parietal cell antibodies.
And remember, because pernicious anemia is autoimmune, it often clusters with other autoimmune diseases. Always consider checking thyroid function for Hashimoto's and screening for type 1 diabetes in these patients.
Good point. Look for associated conditions. Okay, now let's contrast B12 with folate deficiency. Stores are shorter, you said.
Much shorter. We only store about 4 months worth of folate, so deficiency can develop much more quickly than B12 deficiency.
And the causes.
Yeah.
Still absorption problems.
Can be, yes. Conditions like celiac disease affect folate absorption, but often it's due to increased demand, like in pregnancy or if someone has a rapidly dividing malignancy. Poor dietary intake is more common with folate than B12, especially in alcoholism or very restricted diets.
Okay. And drugs?
Yes, certain drugs are notorious folate antagonists or interfere with its metabolism. Methotrexate is a classic example. Also, some anticonvulsants like phenytoin.
Methotrexate, phenytoin. Got it. And folate deficiency causes macrocytosis and anemia, but generally not the neurological problems.
Generally not the SACD or severe neuropathy that B12 causes. You might get some milder symptoms, but the big neurological risk lies with B12.
Okay. And this difference leads to probably the single most critical management rule in this area, right? Something definitely testable.
Absolutely. This is non-negotiable. If your patient has macrocytic anemia and blood tests show that both B12 and folate levels are low, you must always correct the B12 first. Always. Give B12 replacement before you start folate replacement.
Why is that order so important?
Because folate is needed for DNA synthesis and red blood cell production. If you give folate first to someone who is B12 deficient, you give the bone marrow the fuel it needs to start churning out red cells again.
Okay. Sounds good.
It sounds good, but if the underlying B12 deficiency isn't corrected, you haven't fixed the problem with myelin maintenance. By stimulating rapid cell division with folate while B12 is still low, you can actually use up the remaining tiny stores of B12 even faster, potentially accelerating or even precipitating severe neurological damage like SACD.
Wow. So giving folate first could make the neurological situation much worse.
Dramatically worse. It's called masking the B12 deficiency hematologically while allowing neurological damage to progress unchecked. So the rule is absolute. B12 first, then folate. Stabilize the nerves before you boost the marrow.
B12 first. Got it loud and clear.
Yeah.
Okay, quickly touching on other types of anemia. Hemolytic anemia, where red cells break down too early.
Yeah, hemolysis. Red cells normally last about 120 days, but here they're destroyed prematurely, either within the blood vessels and intravascular or by the spleen and liver extravascular.
And this causes the anemia symptoms plus what else?
Plus jaundice because the hemoglobin breakdown releases bilirubin and often hepatosplenomegaly as the spleen works overtime trying to clear up the damaged cells.
Well, how do we investigate?
Look for markers of increased cell breakdown, things like elevated LDH, lactate dehydrogenase, and unconjugated bilirubin. A reticulocyte count will usually be high as the bone marrow tries to compensate.
Okay.
And the absolutely essential test is the direct Coombs test, also called the DAT or direct antiglobulin test.
Coombs test. What does that tell us?
It tells you if the red cell destruction is being caused by antibodies or complement stuck to the surface of the red blood cells. A positive Coombs test points towards an immune cause, like autoimmune hemolytic anemia, AIHA.
Okay, Coombs test for immune causes. And one key inherited cause of hemolysis we need to know.
Sickle cell disease, definitely. Autosomal recessive condition, common in people of Afro-Caribbean descent, involving an abnormal hemoglobin, HbS.
And if you inherit 2 copies of the gene, homozygous, you get the disease.
Yes, HbSS is the most common form of sickle cell disease. Carriers, one gene, HbAS, have sickle cell trait, which is usually asymptomatic.
What are the long-term features of the disease?
Chronic hemolytic anemia, so they're always a bit anemic. Failure to thrive in childhood sometimes. Splenomegaly early on, but the spleen often infarcts itself over time, autosplenectomy, increasing infection risk. Chronic leg ulcers, kidney damage, high risk of stroke, and increased susceptibility to certain infections, especially encapsulated bacteria.
And the thing everyone associates with sickle cell, the acute crisis.
The vaso-occlusive crisis, or VOC, this is the hallmark. The sickle-shaped red blood cells are rigid and sticky. They block small blood vessels, causing ischemia, lack of oxygen, and infarction in the tissues downstream. This presents as sudden, severe pain, typically in the bones, joints, chest, acute chest syndrome, medical emergency, or abdomen, can also cause stroke.
And what triggers these crises? This is key GP knowledge, isn't it?
Absolutely key. The triggers are often simple, everyday things. Infection, even a mild cold, getting cold, becoming dehydrated, significant stress or exertion.
So a GP needs to counsel patients about avoiding these triggers.
Definitely. Staying warm, staying well hydrated, getting vaccinations, seeking early treatment for infections. It's all crucial preventative advice.
And management during a crisis.
It's urgent supportive care in hospital. The pillars are strong analgesia, often opioids, aggressive intravenous fluids to help flush the microcirculation, treating any underlying infection with antibiotics, supplemental oxygen if needed, and sometimes urgent blood transfusions.
Is there any long-term treatment to prevent crises?
Yes, a medication called hydroxyurea or hydroxycarbamide is commonly used. It helps increase the production of fetal hemoglobin, HbF, which interferes with the sickling process, reducing the frequency and severity of crises.
And screening.
Yes, thankfully, sickle cell disease is part of the routine newborn blood spot screening program, the Hill prick test in the UK, allowing for early diagnosis and management.
Okay, moving into our final section, covering more systemic issues, problems with viscosity, and clotting. Let's start with the opposite of anemia, too many red cells, polycythemia.
Right. Polycythemia means an increased hemoglobin level and hematocrit, the proportion of blood volume occupied by red cells. Essentially, the blood becomes too thick, too viscous.
Like sludge.
A bit like that, yes. It makes blood flow sluggish and significantly increases the risk of clotting thrombosis. Like anemia, it's often picked up incidentally on a routine FBC.
How do we classify it? Is it always a bone marrow problem?
Not always. That's the first crucial step. Separating primary from secondary causes. Primary polycythemia vera, PV, is a bone marrow problem. It's a type of myeloproliferative neoplasm, basically, a slow-growing blood cancer.
Okay.
The bone marrow is churning out too many red cells autonomously, independent of the body's normal signals. And the key genetic marker here, found in almost all cases of PV, is a mutation in the JAK2 gene.
JAK2 mutation for PV. Got it. So what are the secondary causes?
Secondary polycythemia is where the increased red cell production is a response to something else, usually increased levels of the hormone erythropoietin.
EPO, the kidney hormone.
Exactly. So what causes high EPO? Most commonly, chronic hypoxia, low oxygen levels. Think severe COPD, living at high altitude, obstructive sleep apnea. The body senses low oxygen and tells the kidneys to make more EPO to boost red cell production.
Makes sense as a compensation. Any other secondary causes?
Less commonly, certain tumors can inappropriately secrete EPO, particularly some kidney cancers or cerebellar hemangioblastomas.
Okay. Primary PV, JKK2. Secondary, high EPO due to hypoxia or tumor. Is there a third type?
Yes, what's often called relative or false polycythemia. Here, the actual mass of red blood cells might be normal, but the plasma volume is reduced.
So the blood is just more concentrated.
Exactly. You see this often in people who are dehydrated or sometimes with excessive alcohol consumption or heavy smoking. Diuretics can also cause it.
So how does polycythemia present? What symptoms should make you think of it?
Often it's asymptomatic and found on labs, but symptoms when they occur relate to that hyperviscosity and sluggish flow. Headaches, dizziness, visual disturbances, sometimes a ringing in the ears, tinnitus. Characteristic symptom, though not always present, is pruritus itchiness, especially after a hot bath or shower.
Itchiness after a bath, that's specific.
It is thought to be related to histamine release from increased basophils. Patients might also get chest pain, angina, muscle pains, myalgia, or abdominal pain due to reduced blood flow or small clots. Some develop a ruddy complexion.
Given that risk of thrombosis stroke, heart attack, DVT, PE, this needs prompt attention, right?
Absolutely. Unexplained polycythemia warrants urgent referral to hematology for full workup, including AKT testing and assessment of red cell mass.
And initial management.
While awaiting specialist review, the main treatment is venesection, basically, removing blood, like a blood donation, to physically reduce the hematocrit and viscosity. High-risk patients are also usually started on low-dose aspirin to reduce the clotting risk.
Okay, venesection and aspirin. Let's move on to another finding that often points to a systemic issue. Splenomegaly, an enlarged spleen.
Yes, finding an enlarged spleen on examination is a significant clinical sign. Patients might complain of a vague fullness or discomfort in their left upper quadrant, or maybe feeling full very quickly after eating early satiety because the big spleen is pressing on the stomach.
Right, and the spleen's job involves filtering blood.
Exactly. So an enlarged, overactive spleen, hypersplenism, can start trapping and destroying blood cells excessively, leading to anemia, low white cells, leukopenia, or low platelets, thrombocytopenia, or even all three, pancytopenia. This can manifest as fatigue, increased infections, or easy bruising.
How do we confirm it's the spleen on examination?
Key features are: you typically can't palpate above the enlarged spleen, unlike a kidney mass. It usually moves downwards and diagonally towards the right iliac fossa as the patient breathes in. And the percussion note over trab space, normally resonant, becomes dull.
Can't get above it, moves with respiration, dull percussion. Got it. Causes are broad, I imagine.
Very broad. Hematological malignancies like leukemias and lymphomas are high on the list. Also, hemolytic anemias, infections like glandular fever, malaria, portal hypertension due to liver cirrhosis, inflammatory conditions. The list is long. Workup depends on the clinical context.
But where the GP's role becomes critically important is if a patient needs or has had a splenectomy, removal of the spleen.
Yes, this is a massive patient safety point, frequently tested. Splenectomy might be done for trauma, sometimes for severe hemolytic anemia or ITP, or as part of surgery for certain cancers.
And the consequences.
The spleen plays a vital role in immunity, particularly against encapsulated bacteria, those with slippery polysaccharide capsules.
Like pneumococcus.
Exactly. Pneumococcus, Streptococcus pneumonia, Haemophilus influenza type B, HIB, and meningococcus, Neisseria meningitidis. Without a spleen, patients are at lifelong, significantly increased risk of overwhelming sepsis from these organisms, which can be fatal within hours. It's called OPSI, overwhelming post-splenectomy infection.
Lifelong risk. So management is crucial. What needs to happen?
Two key things: vaccination and prophylaxis.
Okay, vaccines.
They need vaccines against pneumococcus, HIB, meningococcus, ACWY, and B strains, and also the annual influenza vaccine. The timing relative to surgery matters if it's elective.
And prophylaxis.
Lifelong daily prophylactic antibiotics are essential, usually phenoxymethylpenicillin, penicillin V. If they're penicillin allergic, a macrolide like erythromycin or azithromycin is used.
Lifelong antibiotics every day.
Yes. Plus, they need to know to seek immediate medical attention and start emergency antibiotics if they develop any fever or signs of infection, and they should carry an alert card or wear medical jewelry. This is a critical area for GP oversight.
Absolutely. Okay, let's quickly run through some other high-yield white blood cell and platelet abnormalities we might see on an FBC.
Sure. High neutrophil count neutrophilia, think bacterial infection first. Also inflammation, stress, steroid use, or could be a sign of a myeloproliferative disorder like CML.
Low neutrophils, neutropenia.
Big worry here is infection risk if severe. Causes include viral infections, hepatitis, HIV, chemotherapy, radiotherapy, bone marrow failure syndromes, autoimmune conditions, and importantly, certain drugs. Classic ones are carbimazole, clozapine, phenytoin, sulfasalazine.
Okay, high lymphocytes, lymphocytosis.
Often viral infections, glandular fever, EBV, CMV. But in an older adult, persistently high lymphocytes should make you think of CLL.
Right. Low platelets, thrombocytopenia.
Again, bone marrow problems, leukemia, lymphoma, myeloma, aplastic anemia, increased destruction like an ITP, idiopathic thrombocytopenic purpura, or drug-induced, heparin is a key one, HIT, systemic diseases like SLE, splenic sequestration, sepsis, lots of causes.
And finally, high platelets, thrombocytosis.
This is most commonly reactive secondary to something else. Chronic inflammation is a big cause. RA, IBD, other autoimmune diseases. Also malignancy, post-surgery, post-splenectomy. And interestingly, severe iron deficiency anemia can sometimes cause a reactive thrombocytosis. Less commonly, it can be primary, part of a myeloproliferative disorder like essential thrombocythemia, ET.
Okay, that's a helpful rapid review. Now let's tackle the clotting system itself, distinguishing between those who clot too easily, thrombophilia, and those who bleed too easily.
Good distinction. Let's start with thrombophilia, the predisposition to forming clots, particularly VTE, venous thromboembolism, meaning DVT and PE, can also cause recurrent miscarriage.
And causes can be inherited or acquired.
Exactly. The most common inherited cause by a long shot is factor V Leiden. This is a specific mutation in the factor V gene that makes the factor V protein resistant to being broken down by activated protein C, one of the body's natural anticoagulants.
Factor V Leiden, most common inherited. Others.
Deficiencies in the natural anticoagulants themselves, protein C deficiency, protein S deficiency, or antithrombin deficiency. These are rarer but carry a higher risk. Prothrombin gene mutation is another one.
And acquired causes of thrombophilia.
Lots of these. Malignancy is a major risk factor. Chronic inflammatory conditions, immobility, surgery, trauma, pregnancy, hormonal treatments like the combined pill or HRT. And a really important specific one to know is antiphospholipid syndrome, APS.
APS. Tell us more.
This is an autoimmune condition where the body produces antibodies against phospholipids, which are components of cell membranes. It classically presents with recurrent arterial or venous thrombosis and/or recurrent pregnancy loss.
How do you test for it?
You need specific blood tests looking for anticardiolipin antibodies, anti-beta-2 glycoprotein I antibodies, and the lupus anticoagulant. Diagnosis requires persistent positive results along with clinical events. Important to consider, especially in young people with unexplained clots.
Okay, now flipping to the other side. Bleeding disorders.
Right, problems with hemostasis. We can divide these into inherited and acquired too.
Inherited bleeding disorders was the most common.
By far the commonest inherited bleeding disorder is von Willebrand disease.
Von Willebrand disease, VWS.
Yes. It's mostly autosomal dominant, so affects men and women equally. Von Willebrand factor, VWF, is crucial for platelet adhesion and also carries factor VIII. So in VWD, you get problems with platelet plug formation and sometimes secondary issues with the clotting cascade.
How does it present?
Usually mild to moderate bleeding symptoms, easy bruising, prolonged nosebleeds, epistaxis, bleeding gums, heavy periods in women, sometimes prolonged bleeding after surgery or dental work. Severe VWD is rare.
Okay. And the other main inherited ones, the hemophilias.
Yes, hemophilia A and hemophilia B. These are much rarer than VWD. Hemophilia A is deficiency of factor VIII. Hemophilia B, also called Christmas disease, is deficiency of factor IX.
Yeah, these are X-linked.
Both are X-linked recessive. This means they predominantly affect males, while females are usually carriers. They cause a defect in the clotting cascade, leading to delayed formation of a stable fibrin clot. Presentation ranges from mild to severe, with severe forms causing spontaneous bleeding into joints, hemarthrosis, and muscles.
Management involves replacing the missing factor.
Yes, treatment is highly specialized, involving regular intravenous infusions of recombinant or plasma-derived factor VIII or factor IX concentrate, often managed at hemophilia centers.
Okay, what about acquired clotting problems? Are there any major crises we should know about?
Two important acquired systemic crises involving clotting or related processes. First, disseminated intravascular coagulation, DIC.
DIC. Sounds bad.
It is truly terrifying. DIC is a situation where the clotting system becomes massively overactivated throughout the body, usually triggered by something catastrophic like severe sepsis, major trauma, certain cancers, especially acute promyelocytic leukemia, or obstetric emergencies like amniotic fluid embolism.
Widespread clotting. So lots of thrombosis.
Initially, yes, you get microthrombi forming everywhere, blocking small vessels and causing organ damage. But paradoxically, this process rapidly consumes all the clotting factors and platelets.
So you run out of clotting factors.
Exactly, which means the patient then starts bleeding uncontrollably from everywhere, 5E sites, wounds, mucous membranes. So DIC causes both widespread thrombosis and severe hemorrhage simultaneously.
Embrosis and bleeding. That's awful.
It has extremely high mortality. Treatment is fundamentally about treating the underlying trigger, example sepsis, and then aggressive supportive care with blood products replacing platelets, fresh frozen plasma for factors, cryoprecipitate for fibrinogen, a real emergency.
Wow. Okay. What's the second acquired crisis?
Less of an acute crisis maybe, but a systemic condition to be aware of. Amyloidosis.
Amyloidosis. What's that?
It's a group of diseases caused by the deposition of abnormal misfolded proteins, amyloid fibrils, in various tissues and organs throughout the body.
Protein deposition. Where does it deposit?
It can affect almost any organ. Common targets are the kidneys, causing nephrotic syndrome and renal failure, the heart, causing restrictive cardiomyopathy and heart failure, the liver, the gut, and the peripheral nerves, causing neuropathy.
How is it diagnosed?
Diagnosis requires a tissue biopsy, maybe from the kidney, rectal mucosa, or abdominal fat pad, which is then stained with a special dye called Congo red. Under polarized light, amyloid deposits show a characteristic apple-green birefringence. Identifying the specific type of amyloid protein involved is then crucial for determining prognosis and treatment.
Congo red stain for diagnosis.
Okay.
Finally, to wrap up our clinical journey, just a brief mention of blood transfusion risks. Obviously life-saving, but not without potential problems.
Absolutely. Essential to remember the basics ABO and RHD blood group compatibility, the need for cross-matching before transfusion.
And the complications. What are the big ones to know?
Well, the most feared is an acute hemolytic transfusion reaction, usually due to ABO incompatibility, giving the wrong blood type. This can cause massive intravascular hemolysis, leading to fever, chills, back pain, shock, acute kidney injury, and can trigger DIC. It's a medical emergency.
Okay, hemolytic reaction is number one danger. Others.
Febrile non-hemolytic reactions are more common, basically. A fever reaction, often due to cytokines. Allergic reactions from mild urticaria to severe anaphylaxis. Fluid overload, transfusion-associated circulatory overload, TUCO, especially in elderly or heart failure patients. Risk of transmitting infections, although very low now with rigorous screening.
A lung complication.
Yes, tri transfusion-related acute lung injury. This is a specific serious complication where immune factors in the transfused blood trigger inflammation and fluid leakage into the lungs, causing acute respiratory distress, non-cardiogenic pulmonary edema, within hours of transfusion.
TACO and TRALI. Important to differentiate.
Very. TACO is fluid overload. TRALI is inflammatory lung injury. Both cause shortness of breath post-transfusion, but management differs. Recognizing any adverse reaction promptly, fever, rigors, shortness of breath, rash, hypotension during or after a transfusion is a critical GP skill, even if transfusions usually happen in hospital. Hashtag tag outro.
Right, we have covered a huge amount of ground there in our essential deep dive into hematology for the AKT. To try and synthesize this, pull out the absolute must-knows for your exam prep. It really feels like hematology tests your ability to recognize urgency and act fast.
It absolutely does. Those high-stakes timelines are probably the most crucial takeaway. You need to know those 7 red flags that demand that 48-hour FBC for suspected leukemia inside out.
Pallor, fatigue, fever, infections, bruising, nodes, hepatosplenomegaly.
Exactly. And know the 2-week wait guidelines for unexplained lymphadenopathy pointing towards lymphoma, or those specific positive screening tests triggering the 48-hour myeloma workup. Time is critical in suspected malignancy.
And then in the anemia section, mastering that differentiation. The simple lab value that splits iron deficiency anemia from thalassemia trait.
Is ferritin, low in IDA, normal or high in thalassemia trait. Get that right, and you've cracked microcytic anemia.
And for the macrocytic ones.
Never, ever forget the neurological danger zone with B12 deficiency and that absolute non-negotiable rule, correct, B12, before you give folate if both are low, to avoid precipitating or worsening SACD.
B12 before folate. Burn that one into the memory banks.
What's really fascinating about hematology and primary care is how often the GP acts as the ultimate detective. You start with something incredibly vague, tiredness, maybe some back pain, recurrent coughs,
Yeah, everyday symptoms.
and you use a simple test, like an FBC, looking at the MCV or checking a ferritin level, and that becomes the gateway. That single test might be the first clue that unlocks a diagnosis as complex and serious as multiple myeloma, or helps you differentiate between needing iron tablets versus genetic counseling for thalassemia. It really underscores that vital investigative role.
It absolutely does. And connecting that back to patient care, we talked about sickle cell disease. We covered the acute vaso-occlusive crisis and those common triggers, getting an infection, being exposed to cold, getting dehydrated.
Simple things that can have devastating consequences for that patient group.
Exactly. So let's leave you with this thought. Take that clinical knowledge about sickle cell triggers. How might understanding that really understanding it fundamentally change how you counsel a young adult patient with sickle cell disease about managing their daily life?
Yeah, how specific do you get?
Does it change the advice you give about what job they might do, especially if it involves working outside in winter? Or how meticulously they need to plan hydration if they're traveling somewhere hot? Or how quickly they need to react to the first sign of a sniffle?
How do you translate that textbook knowledge about triggers into practical, life-saving advice that empowers them to navigate their world more safely? It's moving beyond just the exam facts to real-world impact.
Something to definitely mull over. That's it for this focused deep dive into AKT hematology. We really hope this has clarified those key points and pathways you need to feel confident in your triage role.
Study smart, focus on those red flags and differentiators, and we'll catch you on the next deep dive.